Radioimmunoconjugates work through a dual mechanism that combines immunologic targeting with localized radiation delivery. The monoclonal antibody components bind to specific tumor-associated antigens, such as CD20 expressed on a malignant B cells. Once bound, the attached radioisotope delivers beta radiation directly to the tumor, causing DNA damage and cell death.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Sabrina Enoch, theranostics clinical specialist at Highlands Oncology in Rogers, Arkansas, about radioimmunoconjugates. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Sabrina.
Nice to be here, Jamie. Thank you so much.
We're going to talk today about radioimmunoconjugates, which are a subclass of the larger umbrella that we might be more familiar hearing of radiopharmaceuticals. So to start off, could you give us a brief overview of the history of radioimmunoconjugates in the field of oncology?
Radioimmunoconjugates are a specialized subset of radiopharmaceuticals designed to combine the specificity of monoclonal antibodies with the cytotoxic power of radiation. The concept emerged from the need to improve targeting compared to external beam radiation in systematic chemotherapy. Early development focused on B-cell malignancies, particularly non-Hodgkin's lymphoma. Because of the well-defined surface of antigens like CD20, two agents shaped this space, Bexar and Zevalin. Although Bexar was withdrawn from the market in 2014, it is important to emphasize that this decision was driven by logistical complexity, reimbursement challenges, and declining utilization, not safety or lack of efficiency. Zevalin remains the only FDA-approved radioimmunoconjugate currently available and serves as an important proof of concept for modern theranostics.
Thanks so much for covering both that. And I do think that that's an important point, as sometimes we do see that certain drugs are removed from the market. And as you mentioned, it's not always because of safety issues. It can sometimes be just because they are not as heavily utilized. It's production issues. It can be some of the logistic challenges, as you mentioned there. And so thank you for bringing that up, because I do think it's important to include that sort of in the history of the drugs that we're going to talk about today. Let's focus in a little bit on the mechanism of action. Can you describe how they work?
Radioimmunoconjugates work through a dual mechanism that combines immunologic targeting with localized radiation delivery. The monoclonal antibody components bind to specific tumor-associated antigens, such as CD20 expressed on a malignant B cells. Once bound, the attached radioisotope delivers beta radiation directly to the tumor, causing DNA damage and cell death. An important concept for nurses to understand is the crossfire effect, where radiation can affect nearby tumor cells. Even not every cell expressed has the target antigen. This helps explain why these agents can be effective even in heterogeneous tumors.
For patients who are being considered for this therapy, are there any sort of biomarker tests or sort of pre-therapy testing that has to be done that a nurse should anticipate seeing or looking for somebody who is prescribed these therapies?
Yes, Jeremy. So prior to treatment, confirmation of the target antigen is essential, such as the CD20 positivity in B-cell lymphomas. Nurses should anticipate thorough baseline evaluations, which include complete blood counts, platelet levels, and assessment of bone marrow involvement. Bone marrow reserves is particularly important because myelosuppression is the primary dose-limiting toxicity. Understanding these requirements allow nurses to anticipate delays, educate patients, and advocate for appropriate monitoring.
I know you mentioned there really are only two major drugs in this class, and one of those is no longer on the market. But can we talk just a little bit more, describing in more depth this example of this agent that we might see in practice, and just highlight some of the features of that drug?
At present, Zevalin is the only FDA-approved radioimmunoconjugate in clinical use. Historically, Bexar played a major role in establishing these therapy classes, but it's also useful to contrast immunoconjugates with other radiopharmaceuticals, such as iodine-31 therapies, which a lot of places do at this time, used for thyroid diseases, or radium-223 used for metastatic prostate cancer. Unlike those agents, radioimmunoconjugates rely on antibody-mediated targeted rather than physiological uptake or bone affinity.
And now can we talk a little bit about the common toxicities or adverse events that are associated with these drugs? Are there any commonalities that we see across these drugs, maybe with other drugs that patients with cancer might receive?
The most significant toxicities are hemolytic, including neutropenia and thrombocytopenia, which may occur weeks after administration. Infusion-related reactions can also occur, particularly during antibody administration. Because these toxicities may be delayed, nurses play a critical role in ongoing assessment, patient education, and coordination of follow-up care.
What are some of the common pharmacologic related strategies that we can use to either prevent or manage some of these toxicities that you've mentioned?
Strategies, Jamie, include careful patient selection, dose adjustment based on platelet counts, and pre-medications to reduce infusion reactions. Close collaborations with physicians and pharmacy teams ensure safe preparation and administration. Nurses also play a vital role in monitoring laboratory trends over time and intervene early with abnormalities when they are identified.
Thanks for that. And I think we can draw sort of a similarity between what we're talking about here, radioimmunoconjugates, and we've had another episode, another drug class that we've covered is those antibody drug conjugates. And so obviously the conjugate word is the similarity there. And it's acknowledging that these drugs, these radioimmunoconjugates there's two pieces to those drugs. There's two parts to it. And so understanding what are those parts, what parts make up that drug, and then understanding, are there specific toxicities to manage? Are there certain things to be aware of for each part of that drug, whether it's the antibody, or in this case, if it's the radio part of the radioimmunoconjugate. And so there's two sides to that coin, and understanding that we have to be able to identify and address toxicities that result from either side of that combined therapy. It's really important for nurses to have an awareness of what makes up that drug. So thank you for sharing some of those strategies. What priorities would you recommend nurses take to ensure safe handling and follow-up care for patients that they're caring for that are being treated with radioimmunoconjugates?
Nursing priorities, Jamie, include adherence to radiation safety principles, patient-specific precautions when indicated, and coordination of care across departments. Follow-up monitoring is essential, as hemolytic toxicities may appear weeks later. Clear communication and documentation help ensure care across multidisciplinary teams.
And that's so important that you mentioned that, because we share patients across discipline. Radiation to medical oncology obviously is a very common transfer back and forth, whether it's concurrent therapy they're receiving between our modalities, or if it's exclusively given in the radiation oncology space. Those patients still typically do sort of have a medical oncology home. And so, as you've mentioned, communicating about timing of therapy, the timing of when we expect to see toxicities come up, and sharing that responsibility with our colleagues across those disciplines to help manage that patient. Very important. And what are some of the primary education points that you typically communicate to patients and their caregivers when they are about to start receiving a radioimmunoconjugate as part of their cancer treatment?
The main issue that I've seen with patients, that their patient education across, is to address fears related with radiation, clarifying that exposure is targeted, and set expectations for delayed side effects. Patients should understand the importance of follow-up labs, symptoms reporting, and adherence to appointments. Providing clear, consistent messaging helps build trust and reduce anxiety. So what I see with these patients is just to address mainly their radiation fears and how to time, distance, and shield from post-treatment adherence.
I'm sure that's a common fear, no matter how they're receiving their radiation therapy. Am I radioactive? I'm sure is a common concern for patients. And so how do you address that when patients would bring that question up?
I just try to explain to them that radiation exposure is like being next to a flame. The further you are away, the less heat you get, the less exposure you get. These patients can be radioactive to 7 days or up to 3 days. It just depends on how fast they excrete it through their bodies and how with half-life exposure. So it's just educating the patients on radiation safety.
In this situation, radioimmunoconjugates, how do you see physicians, oncology nurses, other members of the care team, how do we collaborate to help manage the adverse events or toxicities, provide that patient education, and really serve as that trusted source of information.
Effective collaboration, Jamie, involves oncology nurses, physicians, pharmacists. Where I am, it's, nuclear medicine professionals also working together. Nurses often serve as a central point of communication, ensuring patient education, safety, and timely management of adverse events. So it's very important that nurses understand that they are key players in this team and that their effective communication affects patients' outcomes.
What do you think the future looks like for the use of these types of agents and their role in the landscape of cancer care?
Only one agent is currently approved. The principles established by radioimmunoconjugates continue to guide development for newer targeted radiopharmaceuticals. Emergent agents aim to improve targeting, reduce toxicity, and expand indications beyond hematologic malignancies. This evolution underscores the importance of nursing education in this rapidly changing field.
Well, Sabrina, thank you so much for joining us today on this episode to briefly go over this, like you said, emerging, still growing field of radioimmunoconjugates. As we get to the end of our episode, we do like to run through a series of some quick summary questions to help highlight some of the important points we've covered today. To start that off, how do you think healthcare professionals should evaluate maybe their hidden assumptions, their implicit bias about caring for patients that are receiving radioimmunoconjugates?
Healthcare professionals can reflect on whether hesitations are based on current evidence or outdated perceptions of radiation therapy. Engaging in education, interdisciplinary discussions, and reviewing updated guidelines can help identify and address these biases.
What do you think are some common misconceptions about radioimmunoconjugates?
Common misconceptions, Jamie, include the belief that all radiation therapies are the same and that these agents cause excessive radiation exposure. In reality, radioimmunoconjugates are highly targeted and carefully regulated.
Sabrina, what's something about this topic that's not often discussed but you wish people knew more about?
An under-discussed issue is how non-clinical factors such as logistics and reimbursement can influence whether effective therapies remain available. Understanding this context helps clinicians appreciate the complexity of oncology drug development.
What additional training or education do you think oncology nurses need to stay current on this topic?
Ongoing education in radiation safety basics and targeted therapy is essential. Interprofessional learning opportunities and continuing education support nurses' confidence.
And are there additional resources for patients or other providers who might want to learn more about radioimmunoconjugates?
Yes, resources include professional organizations, clinical guidelines, and radiation safety education materials developed collaboratively.
Well, Sabrina, thank you again for joining us today and sharing all of your information about this unique, small but growing subclass of radioimmunoconjugates. Really appreciate all of the information that you shared with our listeners. Do you have any final comments to share?
Yes, Jamie, radioimmunoconjugates represent an important bridge between traditional oncology treatments and the future of targeted therapies. Oncology nurses play a vital role in ensuring safe delivery, patient understanding, and collaboration between multidisciplinary teams. So it's very important to educate and also stay up to date on evidence-based practices.
Wonderful. Well, thank you again.
Thank you, Jamie.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.